Namaskaram. This video shall cover the IAP National Treatment Guidelines 2024 on organophosphate and carbamate poisoning. There are certain similarities between these two compounds, organophosphates and carbamates. Both belong to the insecticides, pesticides category of drugs. Both have structural similarity. Both have physiological similarity in the sense they have same mechanism of action. Both of them are cholinesterase inhibitors, that is inhibitors of enzyme acetylcholinesterase. They have similar clinical features and the management of the toxicity also remains the same. Common examples of organophosphates are parathion, malathion, phenethion, diazinon and chlorpyrifos, whereas that of carbamates include aldicarb, methomyl. Commonly known organophosphorus compounds have been classified as follows: highly toxic, intermediately toxic and low toxic. The highly toxic ones are the agricultural insecticides, intermediately one are animal insecticides, and those used for household application and field sprays have low toxicity. Examples of highly toxic one are tetraethyl organophosphates and parathion. Of intermediately toxic organophosphate compounds are coumaphos and chlorpyrifos and triclofos, whereas those with low toxicity include diazinon, malathion and dichlorvos. After absorption from the skin, the lungs and the gastrointestinal tract, these organophosphate compounds bind to the acetylcholinesterase enzyme of the RBC in blood and inactivate the same. And this leads to an excess of the compound acetylcholine in the neuronal synapse, and this is responsible basically for the symptoms of the poisoning. Acetylcholinesterase enzyme, which is bound to organophosphate compounds, undergoes a conformational change. Conformational change means a change in the configuration, and this is referred to as aging. This aging process renders the enzyme permanently inactivated and resistant to reactivation by oximes, and that is why it is important to give the oximes, that is the treatment, as early as possible. The process of aging may take 24 to 48 hours. The diethyl analogues of organophosphates age and reactivate slowly, while the dimethyl analogues of organophosphate compounds age and reactivate rapidly. Unlike organophosphates, however, the carbamates spontaneously hydrolyze from the enzymatic site within 48 hours, resulting in transient inactivation of the enzyme, and therefore toxicity due to carbamates is of a shorter duration compared to the equivalent doses of organophosphates, even though mortality rates are similar with both the compounds. There might be some delay in the onset of symptoms depending upon the route by which the organophosphates are getting absorbed. For example, the delay is of up to 2 to 3 hours if absorption is by the oral or the respiratory route. Delay means delay in the appearance of the clinical symptoms after exposure. It is up to around 12 hours after dermal exposure, and it is around more than 30 days if the poisoning is with some lipophilic organophosphate. This is because they get rapidly uptaken by the adipose tissue and then they are released slowly from the fat stores. Toxic effects can be three. They can be muscarinic or cholinergic symptoms which lead to acute toxicity, then nicotinic symptoms which are primarily neurological, and they are characterized by muscle fasciculations, cramps, weakness, diaphragmatic failure, and then CNS effects in the form of altered sensorium. Occasionally, cardiac arrhythmias, heart block, and QTc interval prolongation can also be seen. If we see the timeline of the clinical features, acute toxicity presents within minutes to hours. The symptoms are characterized by the mnemonic sludge. S stands for salivation, L for lacrimation, U for urination, D for defecation, and GE stands for gastric emptying or vomiting. Triple B is another mnemonic for you to remember. It denotes bradycardia, bronchoria, and bronchospasm, which is typical of the cholinergic toxidrome. Muscle weakness, CNS depression, copious secretions, and bronchospasm may also result in respiratory insufficiency. Another mnemonic which is used to describe the acute toxicity features is dumbbells. D for defecation, U for urination, M for meiosis, B for bronchoria, E for emesis, L for lacrimation and salivation, S is for salivation. Next is the intermediate or the neurological symptoms which occur within 1 to 4 days of exposure of organophosphates. These are seen in around only 20% of the patients. They are characterized by bulbar respiratory and proximal muscle weakness. This is important. Myopathy generally takes place, involves the proximal aspect of the limb first. And this usually resolves in 1 to 3 weeks. But there is another entity which is referred to as organophosphate induced delayed peripheral neuropathy or OPIDN, which occurs within 1 to 3 weeks after exposure, and it is primarily motor involvement, begins with paresthesia and calf pain. Initial weakness is seen in distal leg muscles. Distal involvement is characteristic of neuropathy while proximal involvement is characteristic of myopathy. This is followed by weakness of nerves of small muscles of hand, and then it spreads proximally. It may resolve spontaneously or may even become permanent, so it is a real danger with organophosphates. To diagnose organophosphate poisoning, one can rely on the clinical findings, which include characteristic petroleum or garlic-like odor, along with other symptoms of cholinergic excess in the acute phase especially. Then atropine challenge test can be given, in which you give 0.01 to 0.02 milligram per kg of atropine, and this should be followed by cessation of the cholinergic signs in the form of mydriasis, tachycardia, and dry skin should appear. And finally, you can make use of lab findings like estimate the levels of RBC enzyme acetylcholine esterase activity. In the acute phase, the plasma levels are low, that is more than 50% of the minimal normal value, but this does not correlate with the severity and should not be used to guide the therapy per se. So coming to management, once you have managed airway, breathing and circulation, you look for D, that is decontamination in cases of poisoning. You discard clothing in case of dermal exposure and also do dermal and ocular irrigation if required. Along with this, you may need to do gastric lavage. Toxicity can be minor, in which the symptoms are almost nil, the clinical findings are normal, the acetylcholine esterase enzyme levels are more than 80% of the lower reference range. Or toxicity can be major, which is characterized by CNS signs like altered sensorium, respiratory signs like bronchospasm and bronchoria, muscle weakness or fasciculations, that is nicotinic symptoms, even heart rate abnormalities and arrhythmias, and hypotension consequent to the same. In case of minor toxicity, if the patient is clinically stable for 12 hours, you can simply discharge the patient. In case of major toxicity, however, you need to start treatment with atropine at a rate of 0.02 to 0.05 milligram per kg IV and escalate the dose every 10 to 15 minutes till the signs of atropinization appear. You also need to give pralidoxim at a rate of 25 mg per kg IV over 30 minutes and may repeat after 30 minutes. In severe cases, the dose of pralidoxim is repeated every 6 to 12 hours or by giving continuous IV infusion at the rate of 10 to 20 mg per kg per hour. So, you continue the treatment with atropine and pralidoxim until gradual reduction in the doses of atropine does not cause reappearance of cholinergic symptoms. Meanwhile, you give symptomatic treatment in the form of giving diazepam for seizures. For seizures, you must remember that you need to avoid phenytoin because it may precipitate seizures. If the patient is now stable for 12 hours after oxime therapy, you can shift the patient out of ICU, and if the patient continues to stay clinically stable for 48 hours, you may consider discharge of the patient. Some important points you must remember while managing a patient is that you must avoid succinylcholine during rapid sequence intubation in case you need to intubate the patient for managing the airway, since succinylcholine may cause prolonged neuromuscular blockade. For decontamination, you must wash the eyes with clean tap water, wash the body with soap and water, and forced emesis or forced vomiting is contraindicated due to the risk of aspiration. Atropine in children less than 12 years of age is given every 10 to 20 minutes initially till signs of atropinization in form of decreased secretions and or wheeze Dry, flushed skin, tachycardia, mydriasis and fever is seen. This should be followed by giving atropine every 1 to 4 hours for at least 24 hours. The maximum single dose for neonates 0 to 4 weeks of age is 0.03 mg per kg, and the maximum single dose for children is 0.5 mg. For children more than equal to 12 years of age, you need to give 1 to 2 mg of atropine IV initially. If no response, the dose is doubled every 5 to 10 minutes until tracheobronchial secretions are dry and the patient can be oxygenated. Tachycardia and mydriasis are not contraindications to the usage of atropine. Pralidoxim neutralizes the nicotinic effects. WHO recommends 25 to 50 mg per kg of pralidoxim in normal saline over 30 minutes. This should be followed by a continuous IV infusion of 10 to 20 mg per kg per hour. In case the chloride form of pralidoxim is not available, one can use iodide mesylate metyl sulfate forms by converting the chloride form doses into equivalent dosing of the concerned compounds. The effectiveness of oxime therapy is determined by sequential measurement of RBC acetylcholinesterase activity. This is not indicated for carbamate poisoning. Atropine should continue with pralidoxim to counter the nicotinic effects. Summarizing the key points, acute organophosphate toxicity manifests with symptoms of cholinergic excess, which are defined by the mnemonic dumbbells or sludge and triple B. Intermediate or neurological symptoms occur in 20% of patients within 1 to 4 days of exposure, and they generally resolve in 1 to 3 weeks. The diagnosis of organophosphate poisoning is on the basis of clinical symptoms and signs. One can use the atropine challenge test if typical signs are absent. One must try and identify the precise agent causing the toxicity, as diethyl agents require prolonged treatment with oximes because they reactivate and age slowly. Atropine for muscarinic symptoms and pralidoxim for nicotinic symptoms are used for the treatment of organophosphate poisoning. Thank you so very much for a very patient listening and watching, and I'll be glad if you could give a thumbs up in case you like the video and other videos of the type. Would also be glad if you could share which sign of atropinization do you rely on clinical practice. I'll give my own answer in the comment section below. Thank you once again. Thanks a lot.